Hello everyone, how are you doing? In this lesson, we will explore the clinical manifestations that indicate the presence of cardiac disease, from the most subtle and early signs to those that represent severe hemodynamic compromise. It is important to understand that several signs can be present without necessarily indicating heart failure, and that many of the symptoms we will study can also originate from non-cardiac diseases.
Cardiac disease in dogs and cats is one of the most frequent diagnoses encountered in veterinary clinical practice. However, the clinical signs presented by patients with cardiac compromise are often not specific to the cardiovascular system, making differential diagnoses challenging.
Throughout this presentation, you will understand the pathophysiological mechanisms behind each clinical manifestation, learn to differentiate between signs of pure cardiac disease and signs of congestive heart failure, and understand how to systematically evaluate a patient with suspected cardiovascular compromise.
We will cover the most specific signs, such as heart murmurs and rhythm disturbances, going through systemic manifestations like syncope, cough, and respiratory difficulty, and finishing with the complete semiological evaluation of the cardiac patient.
Let's start with the general signs. Several signs can indicate the presence of cardiac disease, even in animals that do not show apparent clinical manifestations of heart failure. It is fundamental to understand that the presence of any of these signs does not necessarily mean that the animal is in congestive heart failure, but rather that there is cardiac compromise requiring additional investigation. The classical signs of cardiac disease include heart murmurs, which are abnormal sounds heard on auscultation resulting from turbulence of blood flow. Rhythm disturbances, also known as arrhythmias, represent any deviation from the frequency or regularity of cardiac beats. Jugular pulse, which is abnormal visibility or palpability of the jugular veins in the neck, indicates elevation of systemic venous pressure. Heart enlargement, or cardiomegaly, can be detected both on auscultation and on complementary exams such as thoracic radiography.
Beyond these more specific signs, there are other manifestations that may originate from cardiac problems. Syncope, characterized by transient loss of consciousness, may have cardiovascular origin when resulting from severe arrhythmias, outflow obstruction, or inadequate cardiac output. Abnormal arterial pulses, which may be excessively weak or excessively strong, indicate alterations in pulse pressure or stroke volume. Cough, often attributed to respiratory problems, may be cardiac when resulting from cardiogenic pulmonary edema or bronchial compression by left atrial enlargement.
Respiratory difficulty, or dyspnea, is particularly important to evaluate, since it may result from both congestive heart failure and various other pulmonary or systemic conditions. Exercise intolerance represents the patient's inability to maintain adequate physical activity, resulting from insufficient cardiac output or from the vascular and metabolic alterations that accompany chronic cardiac disease.
Abdominal distension, often manifesting as ascites, results from right-sided heart failure and must be differentiated from other causes of ascites. Cyanosis, the bluish discoloration visible on mucous membranes, indicates inadequate oxygenation of peripheral blood and may result from cyanotic congenital cardiac shunts or from severe cardiopulmonary compromise.
It is important to emphasize that non-cardiac diseases can also cause many of these signs. For example, cough and dyspnea may result from primary diseases of the pulmonary parenchyma, airways, or pleural space. Syncope may have neurologic, endocrine, or metabolic origin. Therefore, additional evaluation using thoracic radiography, electrocardiography, echocardiography, and other diagnostic tests is normally indicated when there are symptoms suggestive of cardiovascular disease.
To properly understand the clinical manifestations of heart failure, it is essential to understand what defines this state and what its underlying mechanisms are. Heart failure occurs when the heart cannot adequately meet the body's circulatory needs. More specifically, the heart is unable to adequately nourish the organism, or can only do so with elevated venous filling pressures. This definition is important because it recognizes that cardiac output is not always reduced in heart failure. In some cases, the heart pumps adequate volume, but at the cost of elevated filling pressures.
The clinical signs of heart failure are divided mainly into two categories: precardiac congestive signs and signs of low cardiac afterload, that is, inadequate blood flow out of the heart.
Congestive signs result from retrograde pressure increase. When right ventricular failure occurs, there is an increase in systemic venous pressure and consequent increase in systemic capillary pressure. This manifests clinically as jugular vein distension, ascites, subcutaneous edema, and hepatomegaly. Blood accumulates in the systemic veins because the right ventricle cannot efficiently pump the blood that arrives at it. Left ventricular failure causes elevation of the left heart filling pressure, resulting in engorgement of the pulmonary veins. As the pressure increases retrogradely, fluid extravasates from the pulmonary capillaries into the alveoli, causing pulmonary edema. This manifests clinically as tachypnea, dyspnea, and cough, particularly in dogs.
It is important to understand that some animals develop biventricular failure, with both left and right congestive signs. In addition, chronic left-sided congestive heart failure may promote the development of right-sided congestion signs, especially when there is a secondary increase in pulmonary arterial pressure resulting from pulmonary venous hypertension.
The signs of low outflow, or decreased cardiac output, are similar regardless of which ventricle was primarily affected, because the outflow of the left heart is paired with the cardiac output of the right heart. If both ventricles are in series in the same circuit, the total cardiac output must be equal in both. Understanding the pathophysiology behind weakness, exercise intolerance, and syncope is fundamental for clinical diagnosis, since these are signs frequently presented by the owners.
Animals with heart failure frequently cannot adequately increase cardiac output to sustain increasing levels of activity. This occurs because the impaired heart cannot respond to the increased metabolic demand of the tissues during exercise. In addition, vascular and metabolic alterations that occur over time impair perfusion of skeletal muscle during exercise, contributing to reduced exercise tolerance. Increased intrapulmonary vascular pressure, particularly in left-sided heart failure, decreases pulmonary functional residual capacity, further reducing exercise tolerance.
Episodes of weakness on exertion or exertional collapse may be related to these chronic alterations in cardiac output capacity, or may result from acute decrease in cardiac output caused by arrhythmias. It is important that the clinician carefully questions the owner about the circumstances in which weakness occurs, during exercise, immediately after exercise, or at rest.
Syncope is characterized by transient unconsciousness associated with loss of postural tone, manifested as collapse. It is caused by insufficient oxygen or glucose supply to the brain. Several cardiac and non-cardiac abnormalities can cause intermittent syncope and weakness, which makes differential diagnosis challenging. Syncope must be carefully differentiated from genuine seizure episodes. A careful clinical history describing the animal's behavior and activities prior to the collapse event, together with medication history, can significantly assist the clinician in this differentiation. Syncope is frequently associated with physical exercise or excitement, while seizures can occur at any time.
During a syncopal episode, the animal may present initial muscular weakness of the hind limbs or sudden collapse, followed by lateral recumbency. There may be stiffening of the forelimbs with opisthotonos and urination during the event. Vocalization is common during cardiovascular syncope. However, true tonic-clonic contractions, facial contractions, and defecation are uncommon in cardiovascular syncope, differentiating it from genuine seizures. Aura, which frequently occurs before genuine seizure activity, post-ictal dementia, and focal neurologic deficits are generally not observed in dogs and cats with cardiovascular syncope. These findings help differentiate the origin of collapse.
Some animals with profound hypotension or asystole may present what is called hypoxic convulsive syncope, with activities that appear convulsive or spasmodic. However, these episodes of convulsive syncope are typically preceded by evident loss of muscle tone,
differentiating them from genuine seizures that generally begin with stiffening.
Moments of pre-syncope, where there is reduced cerebral perfusion or substrate supply, not severe enough to cause unconsciousness, may appear as transient staggering or weakness, especially in the hind limbs.
The evaluation of animals presenting with intermittent weakness or syncope requires systematic investigation. The tests usually include electrocardiography tracings performed during rest, exercise, and/or after exercise or vagal maneuver to detect arrhythmias. Complete blood count is important to rule out anemia or alterations in cell count. Serum biochemistry analysis, including electrolytes and glucose, helps identify metabolic imbalances. Careful neurological evaluation can rule out primary neurologic causes. Thoracic radiographic examination is essential to evaluate cardiac size and silhouette. Heartworm tests are particularly important in regions where filariasis is endemic. Intermittent cardiac arrhythmias that do not appear on the resting electrocardiographic tracing can be discovered on ambulatory monitoring with a 24-hour Holter device or through implantation of loop recording devices. In many cases, continuous in-hospital electrocardiographic monitoring may reveal the cause of the arrhythmias.
So far, we have explored the general signs that may indicate the presence of cardiac disease, understood the fundamental pathophysiology of heart failure and its congestion mechanisms. We saw how the impaired heart cannot adequately respond to exercise demands, resulting in weakness and exercise intolerance. And we studied in depth how to differentiate cardiovascular syncope from other causes of collapse, including genuine seizures.
The fundamental concepts you should retain from this first part are: heart failure can occur on both the right and left sides of the heart, each with distinct clinical manifestations. Weakness and exercise intolerance result from inadequate cardiac output and chronic vascular alterations. Cardiovascular syncope is differentiated from seizures and other causes of collapse by specific clinical characteristics, and proper investigation requires multiple diagnostic tests. In the second part of this presentation, we will dive even deeper into the specific clinical manifestations. We will address the specific cardiovascular causes of syncope, including arrhythmias and flow obstructions. We will explore in detail the respiratory manifestations of cardiac disease, particularly cough and dyspnea, and how to differentiate them from primary pulmonary causes. And, crucially, we will study the complete cardiovascular semiological examination, learning how to perform proper inspection, pulse palpation, jugular venous pressure assessment, and systematic cardiac auscultation.
You will also learn to interpret examination findings, such as abnormal heart sounds, heart murmurs in their various presentations, and gallop rhythms. We will finish by completely understanding how the proper cardiovascular examination can guide the differential diagnosis and guide subsequent diagnostic tests. So stay with us in Part 2, where we will connect all these concepts with practical clinical semiology and learn to perform a complete and systematic cardiovascular examination.